Hello, my name is Erica Sainsbury and I'm currently located on Camaragal land in the northern suburbs of Sydney. I'd like to acknowledge the traditional custodians of this land and of country throughout Australia and New Zealand and their continuing connection to land, sea and community. I pay my respects to them and their cultures and to elders past, present and emerging. This presentation is part of a series of conversations initiated by the Australian Pharmacy Council and looking at embedding cultural safety into pharmacy education and assessment. If you've not already done so, I would strongly encourage you to listen to the podcast, which was the first of these conversations. This presentation will be followed by the second conversation, which will be held as a webinar. A couple of years ago, I was commissioned by the APC to write a brief review of the ways that healthcare professional education providers have implemented cultural competency in their curricula. Specifically, the objectives were to look at the extent to which curricula were based on established frameworks, or if they were more ad hoc, and to look at the processes of implementation. However, as I delved into the available literature, and particularly as I read what had been written by First Nations people themselves, I realised that I couldn't stay within these parameters and still do justice to the important issues that kept emerging and recurring. So this review broadened somewhat in scope and depth until we ended up with the final product, which you can read on the APC website. In this presentation, I'm aiming to give a very brief snapshot of some of the important findings. So let's start with what the traditional types of data from a literature search will tell us. I've split these data into two categories. Firstly, the more tangible aspects, and then secondly, the deeper meaning behind them. So it is a relatively straightforward process to identify statistical details, but less obvious is how we come to an understanding of who lies behind these statistics. We can read the historical details of decisions that have been made. We also need to understand how these decisions have had flow-on effects on people's lives. We can download curriculum information, but that really doesn't tell us what students actually learn as opposed to what the curriculum says they should. And we can analyse research findings, but we need to understand the meaning of these findings and, importantly, what they don't tell us and what the research gaps are. And then finally, we need to ask ourselves, what do we do with all of this information? So first of all, what do we know about the statistics? I think most people would be aware of Australian statistics regarding the differences in health outcomes between First Nations and non-First Nations people. And the literature review found that similar patterns exist in the other Kansas countries as well. That is Canada, New Zealand, and the United States. So on average, First Nations peoples have shorter life expectancies, experience higher rates of many common diseases, including oral and dental disease, are more likely to require hospitalisation, and are likely to have poorer access to health services. However, what isn't perhaps as well known is that these statistics are not the whole story. Across these same four countries, there is also a significant pattern of a more holistic approach to health and wellbeing that can't easily be described only using numbers. Indigenous or First Nations conceptions of health are intimately tied to the connections to their lands, communities, cultures, and spirituality. And prior to the arrival of Western societies, they had long and very successful histories of health based on their own ways of understanding and doing and being. This is well captured in this quotation from the National Aboriginal and Torres Strait Islander Health Plan, which talks about a whole of life and whole of community view, where the well-being of every individual and the well-being of the community are interlinked, and where health is not viewed as only physical, but is also viewed from a social and cultural perspective. Similarly, most people would now be familiar with the historical decisions made in Australia, which have affected the ways of life of our Indigenous peoples. This familiarity is in many cases relatively recent, but it is also paralleled by the experiences of First Nations peoples in the other Kansas countries. The experiences are specific to each country, but do have many common aspects. So the arrival of Western colonists has resulted in First Nations peoples' removal from their traditional lands, their inability to take part in their traditional practices, separation from their families and community groups, exposure to new diseases, and then subject to discrimination and discriminatory practices, in the sense that they're unable to participate in the life of their nation in the same ways as their non-First Nations counterparts. However, in order to better understand the situation, it's necessary to look more deeply at the impact of these decisions. Behind many of the decisions that have been made, and that's across all four Kansas nations, is an underlying assumption that First Nations peoples are primitive or childlike and need to be protected. These decisions have also led to the embedding of discriminatory practices into many institutions and areas of life, including that of healthcare. And the outcome of this is not simply bias, but it's active racism. That it is racism has been affirmed by organisations such as APRA and in Commonwealth publications such as the National Aboriginal and Torres Strait Islander Health Plan and the Aboriginal and Torres Strait Islander Health Curriculum Framework. Also, I think many of us are familiar with the significance of social determinants of health, but in the case of First Nations peoples, these are not the only determinants, and the social factors are magnified by the impact of historical and political factors. I think this quotation summarises it quite well. Given the robust evidence that Indigenous peoples have demonstrated very long histories of good health and resilience prior to Western settlement, the current situation can be primarily attributed to historical, political, cultural and social determinants, which have impacted negatively on the ability of Indigenous peoples to practice their culture, resulting in disruptions to cultural identity, family and community connectedness, access to country, and participation in traditional and cultural activities. And it's very clear from the literature that two additional critical outcomes are also apparent. Firstly, the outcome of the social, political, historical, and cultural forces at work have led to deep trauma. And this trauma is experienced not only by the people directly affected, but also continues through generations. And secondly, the discourse, or the ways that Indigenous matters are discussed and reported, has become by default a deficit discourse. What I mean by this is that the conversations have been primarily framed around the problems experienced by First Nations peoples. And this discourse has largely gone unchallenged over a long period of time. Towards the end of this presentation, I'll offer an alternative suggestion for how this discourse could be framed more positively. If we move on now to what the literature tells us about the ways in which Indigenous content is included in health professional education curricula, we can say that the four Kansas countries all have frameworks and approaches to this. In Australia, for example, we have the Aboriginal and Torres Strait Islander Health Curriculum Framework, which has been around since 2014. There are also a good number of published examples of how Indigenous content has been taught. However, what is noticeable is that in most cases, content has been added into the curriculum, but taught in the same way as other content. There are only a small number of published examples where First Nations people have been significant drivers of the process, or where the delivery has taken account of Indigenous ways of knowing, being and doing. However, having said that, I was able to identify some great examples which are described in the review. However, much more common was a rather piecemeal approach, where little change was made to the learning environment or ways of learning. In addition, some authors have drawn attention to the power of the hidden curriculum. What they mean by the hidden curriculum is the set of influences that function at the level of organisational structure and culture, which mediate between what is taught through the formal curriculum and what is really learned by students. These influences are tacit and unwritten, but powerful in that they shape the way students interpret their education and are enculturated into their professions. For example, the amount of resources that are made available for various parts of a curriculum can send a message about what is actually valued by the institution. And this message can undermine espoused values if it's not consistent. Similarly, if students are rewarded for particular behaviours, they may choose to adopt those behaviours which appear to be valued by the institution in order to be rewarded, rather than adopting behaviours which appear to be less valued. And this potential misalignment between the formal, informal and hidden curriculum can then entrench and perpetuate negative stereotyping, discrimination and racism where it comes to Indigenous issues. And finally, we can look at what the research tells us about the impact that including Indigenous content into curricula has had. The vast majority of published research has focused on evaluating changes in student attributes, such as their knowledge, attitudes, confidence, and awareness of Indigenous issues. And there's certainly evidence that these can be significantly enhanced through education. But there's also evidence that the effect can be quite short-lived, and also that in a number of cases, there is student resistance to learning. Now, this resistance may often be as a result of prior beliefs, but there are a number of other reasons, which I discussed more fully in the review. What is conspicuous, though, is a paucity of research which has linked teaching and learning to either changes in professional practice following graduation, or more importantly, to improvements in health outcomes. Now, this is clearly a difficult endeavour, and many authors have noted these difficulties, but difficulty does not negate the relevance and importance of undertaking this research. What is also clear is that curriculum design is not a one-size-fits-all approach. There are some examples where links have been made between curriculum and practice change and improvement in health outcomes, but they are very specifically linked to a local context. So then, what does the literature tell us about what seems to have had the most effect? A promising theme running through a number of approaches is that learning should be first and foremost viewed as a process of personal transformation, where individuals first reflect on their own assumptions, values, beliefs, biases, and so on. Having done this, they are then challenged with something that doesn't fit into this personal framework. Now, this could be new evidence that they encounter, or it could be a new experience that they've never undertaken before. And this challenge creates a space for them to reconsider their original position and potentially to change. The research strongly suggests that this process is promoted by engaging in authentic cultural interactions and conversations. And these can be either in the classroom or in placements within Indigenous communities. What is also very strongly recognised is that acknowledging Indigenous perspectives of the social, historical and political causes of inequity is an essential part of this personal transformation. And this leads on to the need not only for personal transformation, but also transformation of the whole learning environment. Overall, it can be summarised by the phrase, nothing about us without us. And the other points on this slide summarise the findings, which you can explore in more detail in the review. I particularly want to highlight the first point and talk further about cultural humility and cultural respect, because I think these are good starting points for transformation. But first, we need to think about what our goal as educators might be in this space. As I've spoken to many people about this and read around as much as I can, it's the concept of cultural safety which comes up again and again as our goal. That is, we need to focus on creating culturally safe healthcare experiences for all individuals and for their families and their communities. So we therefore need to understand what cultural safety looks like. This is way too large a topic for me to do justice to in this brief presentation, but at the very least, we need to recognise that cultural safety and cultural safe spaces are defined not by the provider of care, but by the recipients of that care. We need to acknowledge the responsibility of both healthcare professionals and the organisations within which they work for creating and maintaining these culturally safe spaces. We need to understand that cultural safety is built on both individual self-awareness, but also collective social accountability. Cultural safety is promoted by demonstration of cultural humility and respect. And again, the presence and impact of intergenerational trauma as a result of individual and community experiences of discrimination, racism, dispossession, and humiliation must be acknowledged and redressed in creating cultural safety. This definition is a recent definition of cultural safety, and I think it's a helpful one. Cultural safety requires healthcare professionals and their associated healthcare organisations to examine themselves and the potential impact of their own culture on clinical interactions and healthcare service delivery. This requires individual healthcare professionals and healthcare organisations to acknowledge and address their own biases, attitudes, assumptions, stereotypes, prejudices, structures, and characteristics that may affect the quality of care provided. And so where do we start? I'd like to suggest that a good starting point is the cultural humility and respect that I mentioned earlier. Cultural humility, it means admitting we don't fully understand what it is like to be anyone other than ourselves, that we have our own culture and others have theirs. But it's also a commitment to being open, to listening to others, and to building relationships based on mutual respect. And cultural respect is about looking for and acknowledging the strengths of others. So I find this quotation, which is the voice of an Australian Indigenous elder, is very powerful. And it's particularly powerful because at the heart of it, it refutes the deficit discourse and offers in its place a strengths-based discourse. So speaking as an Indigenous person, we represent the oldest continuous culture in the world. We are also diverse and have managed to persevere despite the odds because of our adaptability, our survival skills, and because we represent an evolving cultural spectrum inclusive of traditional and contemporary practices. At our best, we bring our traditional principles and practices, respect, generosity, collective benefit, collective ownership, to our daily expression of our identity and culture in a contemporary context. When we're empowered to do this and where systems facilitate this reclamation, protection and promotion, we are healthy, well and successful, and our communities thrive. So cultural respect, at the very least, is about changing from a focus on problems to a focus on positives, to acknowledging that the oldest living cultures in the world have wisdom to offer other cultures about health and well-being, and that working together respectfully will benefit all of us. So then, as health professional educators, how could we start thinking about framing or reframing our education practice? Well, from the research, I offer 7 principles, which the research suggests could form the basis for how we start to think about reframing health professional education in Australia. Now, in this presentation, I haven't spoken about all of the points on this slide, but you can certainly find more in the literature review. Firstly, let's focus on learning as a means of promoting individual and collective transformation. Secondly, let's seek to create partnerships built on genuine and respectful collaboration of equals. Let's ensure our students are sensitised to their responsibilities as both advocates and agents of change. Let's aim to decolonise and indigenise not only curricula, but also the environment in which learning takes place. Let's seek to align the hidden curriculum with the formal and informal curricula. Let's adopt a strengths-based discourse to acknowledge and value the strength, resilience and value of the oldest living continuous cultures of the world, their languages and spiritual relationships with the land and waters. And let's look through a social accountability lens at our decision-making, implementation and evaluation. Thank you very much for your time. For further reading, you can access the literature review at this address, or you can simply go to the APC website and search for literature review.